Holli. I'm from McMillen Health, which is located in Fort Wayne, Indiana. And we do health education statewide, nationwide, face-to-face. We do a lot of video conferencing, live video conferencing education, and we also write curriculum. So because we educate in both Indiana and nationwide, we work with a lot of rural populations. We work with a lot of really rural populations, like Canadian populations and some of the Western populations. But I've had a really special interest in both rural populations and how do we use mobile health to reach rural populations, because I know some of the issues that we face. And I remember when I was working in Northwest Ohio, I used to go to the state meetings, and they would always say things like, well, I don't understand, why you struggle with these things. Just give people bus vouchers or things like that. And I would always say, you don't understand, what it's like to work in rural areas. We don't have buses. We don't have cabs. So we really struggle with reaching people. And I have really developed an interest over the past few years in mobile health. And so we will be talking about that today and talking about some of my research and then about some of the really interesting things that are out there. So our learning outcomes for today are just understanding what mobile health is. We're going to talk about multimedia text messaging and the promise for that in rural health, and then how some ways that we could incorporate mobile health into practice today. So this is a lot of what I do. I work a lot in oral health. We work in all aspects of health. And we're right now, some of our big projects are working on opioid education and trying to get that into the schools. We have a statewide pregnancy prevention program, but a lot of my work is in oral health. We have the BRUSH program, which is the nation's largest program on oral health, and we work predominantly through Head Start and through WIC. And we work in a lot of rural areas. And this was really how I entered into mobile health. And the definition for mobile health is just the use of mobile and wireless devices to improve health outcomes or services, and also to do health research. And in my research, we have used mobile phones to collect research answers for several different projects that I've been involved in. So it's a pretty broad description, and I tend to tighten it up a little bit for my work. And there's often a little bit of confusion as to what is the difference between mobile health and telehealth. And telehealth, the term typically is more for use in a healthcare setting. So it's potentially using video conferencing to bring in an expert opinion when you don't have access to an expert opinion. When I was in Northwest Ohio and working with families who were on their Help Me Grow Home visiting program, what we really struggled with was access to child psychiatrists and child neurologists. And so telehealth is great when the nearest expert is 2, 3, 4 hours away, that you can video conference them in to talk to the patient or to get an expert opinion. So mobile health tends to be a little bit different. Mobile health is direct to consumer. So we're sending messages direct to the patient or consumer, or we're interacting with them on their mobile device to improve healthcare. And some of probably the most popular mobile health interventions have been around smoking cessation and text messaging people messages to help with smoking cessation. Diabetes has been a really popular mobile health intervention. There's been a few studies for new diabetic patients, sending them text message reminders, questions and answers, reminders of when to take their meds, do their blood sugar testing. So we see mobile health a lot in chronic disease management, and then when we have people who are trying to stop a detrimental health behavior like smoking. What we haven't seen mobile health in as much is in prevention, and that's the work I do, is prevention. So that's where we haven't really used mobile health as much. And the one thing we have to remember about mobile health is this is so new, that the research is not broad and deep. There's been a lot of studies out of Africa. There haven't been, really tight studies. There haven't been as many studies in the U.S. As far as there have been in other countries. And when I did my research, when I was doing like my lit review for my dissertation, most of the high quality research on mobile health is coming out of New Zealand and Australia. And we're definitely not leading the field in this yet. But I think in the next few years, we're going to see some really exciting interventions. So as far as I see it, this is where mobile health really holds promise for rural health. In overcoming our issues with distance and transportation, issues with staffing, rural hospitals, rural health care typically is not able to staff the type of, the number of staff and just having staff present. And then also the expertise is often not there because the specialists tend to be in the cities. Direct messaging, a lot of our health behaviors and our prevention requires constant reminders. We have tended to be really paper heavy in public health, and it's probably the worst way to communicate with people because of health literacy issues. Mobile health has the amazing potential to overcome a lot of health literacy issues through the use of short messages and short video. Video is going to really revolutionize public health in helping people understand how to do things, when to do things, why to do things. So this is some of the promise I see as far as working in rural areas. And we're going to talk a little bit later about an intervention designed for lactation consulting, but lactation consulting is a huge example of where mobile health can help. Often moms in rural areas, if they need to see a lactation consultant, the distance and the transportation issues are huge. Our rural hospitals often don't have lactation consultants on 24/7 like our more larger hospitals do. And so this is an area, and we're going to talk about an intervention actually designed for that, that can really help with some of those issues. So this is sort of where I'm coming from with the research I'm going to talk about today. This is our brush chart of how we are trying to impact children's oral health. And this is really how we work with everything. When we have children at the center, we have some key groups that we have to reach to impact a child's health status. Obviously, the early childhood educators who work with children, the dental and primary care fields who see children on a regular basis. But parents are absolutely critical for oral health. And when we're trying to change a child's oral health status, if parents aren't on board, that's really not going to be possible. So we make these great print resources, and they're great. They're low literacy, they're really easy to use, they're Spanish and English, but this is the problem. This is the problem I face. Parents are hard to reach, rural parents are harder to reach. So when we're trying to get any type of materials to parents to look at changing a child's health status, it's hard to do. It's hard to, I can give the print materials to the Head Start or the WIC. Does their staff hand them out? I certainly hope so. If they do hand them out, do they get home with parents? Have they lost them by the time they get home, or they're crumpled up in the back seat of the car? It's an issue. It's the issue everybody in public health faces and in primary care. And then when we talk about rural parents, we just add an extra layer onto that issue because they see less messaging. It's harder to get them places because of distance and transportation. So we have less opportunities. So Head Start's a great example. We work with Head Start nationwide. We're reaching over 100,000 Head Start children. Head Start parents in urban areas are much easier to reach because they tend to walk their children to the Head Start location or drop them off because it's close. So parents are seeing Head Start staff a lot, and there's a lot of opportunity to give them something or tell them something. When we get into the rural areas, those kids are being bused. The Head Start staff rarely see the parents face to face, so it becomes much more difficult to give them a health message face to face. Now, you can certainly send something home in a kid's book bag, but anybody who goes through a kid's book bag knows that that's probably not, the best way to get information to parents. So a few years ago, I started seeing a lot of this, and I travel a lot. I work nationwide. I'm in a lot of Medicaid clinics, WIC, Head Start conferences, and I started seeing this a lot. And when I start seeing things like this, I look at this as opportunity. Anytime, my feeling in public health is anytime we're annoyed at people's behavior, that's probably the opportunity to use that behavior to educate them. Facebook's a great example. We get annoyed that people are always on Facebook, our staff are on Facebook. That just becomes an incredible opportunity for education. So I started seeing this in waiting rooms wherever I went. And I started going into Head Start meetings, and there'd be a big sign that would say, please put your phone away while you're in the meeting, with our health manager, or while you're in your teacher conference. Please turn your phone off and put it away. So it's obviously, it's an issue, right? So I see that as huge opportunity. And a recent, one of the Pew Charitable Trust is the one that really collects most of the cell phone statistics. And they came out with one recently that said that young people, which they defined as adults under 30, primarily use their cell phone to alleviate boredom and to avoid other people in the room. And that really describes a waiting room, the two things that you want to do in a waiting room. And so one of the things that's really important to understand when we talk about cell phone usage is the difference in the way that we use cell phones based on our economic level. People at the highest economic level use their cell phones much less than people at the lowest economic level. And that is because when we're at the higher economic levels, we have a lot of other communication tools, right? We probably have a landline. We probably have a landline in our office and in our home. We have a laptop. We have a lot of other ways to communicate. Our cell phone is not our primary communication device for many of us. It is an important communication device, but let's be honest, if we forget our cell phone at home, it's often wonderful. It's an absolutely wonderful day where it's not interrupting us. Our low-income population is very, very different. The cell phone is their landline. They don't have a landline. They have a cell phone. It is their computer. This is the way they're accessing the internet. They typically don't have a laptop or desktop computer that they're using. It's often their cable TV. They're streaming through their cell phone. It's certainly the way they're communicating by text message, by social media. 90%, in my research, 90% of parents were on social media daily, predominantly Facebook. It's the way they bank. If they go to look for a job, it's how they're filling out job applications. If they need to find housing, it's how they're finding housing. And this is just the tip of the iceberg. The mobile phone is critically important to our lower income populations. They are not walking into a bank or doing banking on their computer. It's their phone predominantly. So it becomes a very different relationship with the phone than what you and I may have with our phone. And often I hear, well, low-income people don't have nice phones. Yes, they do. So that is where almost all of my work is with low-income populations. And not all our rural populations are low income, but we have more low income in the rural areas, and we have poor health outcomes. So it's important to know what their relationship with their phone is when we're looking at using the phone. And it's really an amazing relationship because for the first time in human history, we are carrying with us an electronic device that is completely unique to each of us. My cell phone and your cell phone, even if you have the same Android I do, are not the same phone because my ringtone, my social media, my email, my apps are on my phone. Once I've started using it, my phone is completely different than anyone else's phone in the world. And we're using our phone for everything. I mean, how many of us still have a watch or an alarm clock anymore? So this has become a really, really important part of our daily lives, and it's a very personal part. And because of that, there seems to be an emotional difference in delivering messages over this very personal piece of electronics versus giving messages to people by paper or even sometimes in person. So as someone in public health, I look at that as incredible opportunity. And this has been backed up by research studies, and in my own research included, but there was also a great study out of Sweden or Denmark, one of the Northern European countries, on young people who were drug users and, well, cannabis. And they were sending them text messages on reducing their use. And one of the repeated comments that came up in the interviews was that the messages were personal to them. They weren't personal to them. The same messages were going out to everybody in the study, but there was a belief that because they came over their cell phone into their personal text messages, that the messages were personalized. So this is what I'm going to talk about today, because it's the only study like this. So I kind of have to talk. This is the only one to talk about. But this is my research. And what I did was I sent multimedia text messages, and a multimedia text message is a message with a short video. And I mean short. You don't. I mean 30 seconds to a minute. People don't want to be watching stuff forever. So I sent, one thing that was unique is it was the first study in the US to use multimedia text messaging for health messaging, but it was also the first study of its kind to send messages directly to children. So I text message parents, and then the next day a message came over parents' phone aimed at their children. And this was an oral health intervention. And basically what we were looking at here was, would we see behavior change with toothbrushing, but also were people receptive to this? Were they receptive to us sending messages directly to their children through their phone? And these were Head Start children, so they were ages 3 to 5. So the way the study was set up was parents got a package of materials before the study started. It had a children's book and a brushing chart and a toothbrush. And then they got a little letter of instruction saying, on Wednesday, we will send you a parent message with a short video on a certain topic, say nutrition. On Thursday, we will send your child a message that starts with, "Hi kids," so you know it's for your child. And that will also have a short video on the same topic that you learned about the day before. Those messages also had a parent-child interaction activity, and that was tying into Head Start and their importance on parent-child interactions. So these are actually the two messages about bedtime. Only 60% of Medicaid parents brush their children's teeth twice a day, and the brushing they're most likely to skip is the bedtime brushing. So we focus one of our weeks, this was a 5-week intervention, one of them focused on bedtime and preparing for bedtime and incorporating brushing into bedtime. So we ended up with 142 parents from rural Indiana, actually Northeast Indiana, in this study. And we asked them a lot of questions about how they used their cell phones before they were divided into control and intervention groups, because I really wanted to know how they were using their cell phones and how they would perceive receiving health messaging through their cell phones. So what we found in this study was really high rates of owning cell phones and watching video on cell phones. And we have Facebook to thank for that. Facebook streams over 1 billion videos a day. That has been really phenomenal for doing mobile phone interventions with short video. When I was looking at any multimedia interventions that have been done before, there was only one in the literature out of Australia. It was done about 5 years ago, and it was just done too early. And a lot of people did not have phones that you could watch video on. and a lot of people didn't understand how to watch video on their phones. That's not an issue anymore, thanks to Facebook, thanks to our cameras that have video on them. That's become a very popular use of the cell phone, and all you do is click on it and it plays automatically. And 87% of the parents in my study were using their phone to watch videos, and that was predominantly through Facebook. What I found that was really unusual, and I did get to the bottom of why this was, is that I had a really high rate of parents in the study who had not changed their phone number and had not had interruptions to their phone service in the last 6 months. When I talked to a lot of direct service providers about low-income families and individuals, the one thing I will hear over and over again is their phone numbers change so much, their phones are always out of minutes. That's often not really the case. What is the case is that often our low-income families have two cell phones. They have their personal cell phone and they have the government-provided cell phone. You may hear those called Obama phones. In Indiana, a lot of those are SafeLink, by the company SafeLink. So anyone, if you're not familiar with this, anybody who receives any type of government subsidy program qualifies for a free or very low cost cell phone. And this is a nationwide program. This is not an Indiana program, it's a nationwide program. It was actually started under the Reagan administration for landlines. It was really expanded under the Obama administration, which is how they got the nickname Obama phones. But anyway, often families will have this free phone, and that is the phone number they give to people who are not friends and family. So often they have a very stable personal phone number. They're not giving you that phone number. The phone number that they're giving to non-friends and non-family is their government phone, which may often be out of minutes, and they may often be changing that number a lot. In my qualitative research, that's where this really came up. Because in this study, we were able to get more personal phone numbers, they had not, those numbers had not changed. And this was really big, this last bullet point, no extra charges. This was huge. When I was first proposing this project, I had a lot of problems getting it through IRB because the IRB committee felt that low-income families would incur a lot of charges. That 93% of my low-income families said that's not a problem. Most of them have really high data plans, or they're tapping off of someone else's internet, their own internet, or internet at work, or internet in public places. They had really no concerns about using all their data, and they're very savvy. You know, most of the parents I talked to were extremely savvy about how they use data. So it was absolutely not an issue for them to receive short videos. This attitudes, this was good and bad information. Less than 20% of the parents in my study had received any health information through their cell phone, which is really low. All of these parents had babies after Text for Baby was created. We're not doing a great job referring our parents, especially our rural parents, to apps and to text messaging that could help them stay healthier. Text for Baby I'm going to talk about a little bit later, but it's probably absolutely one of the best free services out there. However, 80% were open to receiving that information. So they're not getting it, but they're open to getting it. We did have a behavior change doing this. So sending 5 weeks of short multimedia text messages, we did have a statistically significant change in toothbrushing children's teeth and in brushing parents' teeth, which was not something that we were pushing, but has been seen as a corollary effect in other studies, where if you encourage parents to brush their children's teeth, they do tend to brush their own teeth more often. Now, what we did encourage, because this study was based on social cognitive theory, what I did really encourage was role modeling. And in the videos, we encourage parents to brush with their children and to brush in front of their children. So while we weren't telling them to brush their teeth more, what we were saying to them is, you're a really important role model to your children. And if they can see you brush your teeth, it's more likely that they'll be willing to brush their teeth. So we did see differences in the behavior that we were trying to change, which was a prevention behavior of brushing teeth. Then we really asked a lot of questions of our intervention group as far as, did you have any issues with this? 86% of our parents didn't have any issues watching the videos. They were satisfied with the videos. They would recommend the intervention to a friend. We were really encouraged to see that 84% said that text messages with videos strongly encouraged their child to brush their teeth, and that they were doing the parent-child activities. So then we sat down with parents and talked to them, did some qualitative interviews about the intervention. One of the concerns I had with just doing survey data was that this is all so new and so different. It's really hard to capture that in survey data. So sat down with parents, and what I found was overwhelmingly what they loved was their child getting text messages. Young children don't get a lot of text messages. And so when they would get this short video that was fun and encouraging, the kids loved it. They watched it repeatedly. They knew what day and time the video was due to get there, and they would ask about it. Some of the parents did really cool things. One of the grandmothers who had custody of her granddaughter in the study said that she would save the message, and then at night when they would get in bed to, do their nighttime routine, read a book, she would show her the video that night, and they would talk about it, and that way she could really watch it with her. Parents overwhelmingly said, yes, this really changed my child's attitude towards toothbrushing, and it motivated the children because they are pre-readers, and so when information comes home that's in print form, the parents can read it to them, but they said this was empowering to the children because they could push the play button, they could watch it themselves and get the message. And then one of the corollary outcomes of those interviews, which at some point I'd like to follow up on, was the perception of the parents that the information that was in the videos was somehow more accurate or more right than other information that they'd been given. And one of the moms said to me in the follow-up interviews, I asked her if she'd learned anything new in the videos, and she said, yeah, I learned that I'm supposed to be brushing their teeth twice a day. I thought once a day was okay. And I was really shocked because this was a mom who'd been in early Head Start and Head Start, which has a strong emphasis on brushing teeth. And I was really shocked that she said that. And I said to her, well, after you learned that information, did you start brushing their teeth twice a day? And she said, oh yeah, I started. And I said, well, how did they react to that when you changed from once a day to twice a day? And she said, oh, they were thrilled with it. They were getting the videos that said they were supposed to brush twice a day. And this was really interesting to me. And there hasn't really been any research done as far as people's perception of something coming over their phone in a video format as being more impactful than information they've been told face-to-face by their preschool teacher or by their dentist, because I knew this was not the first time this mom had heard this information, but for some reason it really resonated with her when she saw it in video format. And this was a great quote from one of my parents that kind of really summed up what the parent said, was that if you send a paper home, it's like whatever, but they'll watch a video. And they really liked the text and video because it was immediate. It didn't get lost in the translation home from school. It was delivered right to their phones. And I think if we look at how we prefer to receive information, whenever somebody says, here, I'm going to give you this paper with this information, the first thing I say is, do you have that in an electronic format? Can you text it to me? Can you email it to me? I'm going to lose that paper, but if I have it electronically, I'm going to be able to go back and look it up. So most of us, that is the way we want to get our information. If you ask primary care or dentist's office what their patients are saying for reminders, predominantly it's just send me a text message. Don't call me, don't mail me a postcard, just send me a text message. I'll be able to get it, look at it, save it, I know where it's at. So it is a really, really convenient way to receive information. And I've been working, we do a lot of materials redesign for people who work with low income and rural populations. And one of the key things that I'm doing is really encouraging when we're sending home permission slips, say for a clinic at the school, or something parents have to fill out and send back to get health care for their children. It's like, please put that electronically. Yes, send the paper home, but also send text messages to the parents where they can click the link, do the online permission form. The rates of return are going to be so much better than a paper that comes home. You have to fill it out as a parent. You have to then return it to the school. There's just a lot of opportunity for that to fall apart, where the paper gets lost or misplaced or not filled out at some point. Whereas direct to phone, we're going to have much, much better rates. So a few ways that we can use this in practice. First of all, I think we need to be getting into the practice more often of looking at what apps are out there for people who are struggling with health issues. And there are an incredible amount of apps out there that can do constant reminders, that can track. There's a lot of things out there for diabetes. Obviously, Fitbit, which is not a low-cost intervention, but there are daily tracking to keep track if you're looking at nutrition or weight loss or maintaining a healthy weight. There's a lot out there. I tend to look at what impacts children because a lot of the work I do is with children. This is a fun related to oral health. Brush DJ sends you a reminder to brush your children's teeth and then plays 2 minutes of music off your phone and pulls from your playlist 2-minute snippets for the 2 minutes of brushing that you should be doing. If you don't have a playlist on your phone, it'll do the top 40, or you can pick whatever genre of music that you like. And we tend to do electronic interventions with a lot of the work that we do, even if it isn't like this, a daily reminder. We're working on materials for children with special needs with oral health. One of the best interventions that one of the best ideas that we've gotten from parents is to bring the phone or tablet into where you're brushing teeth, and if children have severe behaviors or are resistant to toothbrushing, to let them watch a short video for 2 minutes while you brush their teeth, so that distracts them. And distraction is often very effective. So this is Text for Baby, and I really, really recommend that anybody working with pregnant women is pushing Text for Baby. It is a free service. They have agreements with all of the major carriers that they will not charge their cell phone rates when pregnant women are receiving Text for Baby. Text for Baby sends 3 messages a week through pregnancy and the first year. And what's really cool about it is it's tied to the mom's week of pregnancy. So if you're 20 weeks pregnant, those 3 messages a week are geared towards being 20 weeks pregnant. So it's, what is fetal development like? What should you be doing right now? This was originally designed as a intervention to prevent preterm birth in low-income minority women. And it's since gone nationwide, and it's just a great infant mortality prevention app. As mom gets closer to delivery, they're going to be talking about signs of labor, safe sleep, car seat safety. The messages are really, really well done. And it's kind of interesting because the woman who did the multimedia text messaging intervention in Australia that did not work, although it was a great project, actually is a consultant now for Text for Baby. And she's, one of the premier people in designing really high quality messaging. And So they've done some studies on this, and it has shown that women who receive Text for Baby feel that they're more prepared for motherhood, that they've had a healthier pregnancy, they keep more of their prenatal visits. And then the first year of life, they're doing things like immunization reminders, flu shot reminders. They've had great results on sending moms in Text for Baby flu shot reminders, and that they've seen that Text for Baby moms get the flu shot for their children at a higher rate than moms who don't receive Text for Baby. So it's a great intervention, really easy to sign up for, and again, it is a free intervention. This intervention is not free, but it's great. This is Pacified. Pacified is brand new. I just heard about it last week at the National WIC conference. Pacify was started, and this is what is so interesting about mobile health, is that often we have people creating these apps that are data analysts. So this app, it's a lactation consulting app. I assumed it was created by a lactation consultant. No, it was created by two 30-year-old data analysts for Medicaid. They were analyzing preventable emergency room visits for infants. And the number one preventable emergency room visit was lactation issues, where mom had an issue and wasn't able to get a hold of a lactation consultant because of either cost or distance, or there wasn't one on staff, at the hospital during the time she needed it. So mom ends up in the emergency room with a lactation issue, mastitis, not producing enough milk, something like that. Or baby ends up in the ER with a lactation issue. Baby's not latching on and not getting enough milk and is dehydrated. Or mom is eating something that's causing baby to throw up all the milk. It's an allergy issue or something like that. So when they looked at how could you prevent these emergency room visits, the number one answer was 24/7 access to a lactation consultant. Well, that's really difficult, isn't it? If you maybe live 3 hours from the nearest hospital. So they decided live video feed online lactation consulting. So this is a super cool app. It is $15 a month, which I've paid for lactation consultant visits. They're nowhere close to $15 a month. You're looking at, probably $100 a month or $100 a visit. So for $15 a month, moms get unlimited access to 24/7 lactation consulting, nurses, and pediatric nutritionists. So in looking at our low-income populations, a lot of WIC, mostly WIC offices and rural hospitals have been contracting with Pacified to offer this as a free service to their parents. So if you happen to work in a rural hospital and you may have a part-time lactation consultant, this is an extra add-on that can give women 24/7 access. So they turn the video, so it's like this, it's like a video conference. So mom has the video on her phone, lactation consultant has the video on her phone. They can see each other, lactation consultant can see the baby's latch, can give mom advice. I think this is going to be phenomenal. And I think you're going to see more and more of these applications come out of what is your biggest problem? How can we create something that will help with that problem? So that is really the question I end with. What's the biggest problem? How can mobile health be a resource in that problem? So for instance, in really looking at your data analytics of where are we facing, big issues? And I look, for me, it's children's oral health, which is the number one disease of children, and it's completely preventable. How do we then use mobile health interventions to help alleviate that? So if you work in a primary care facility or in a hospital, what are the biggest problems that you're facing? And then how can we potentially use mobile health for that, whether it's putting forms online, whether it's reminders, whether it's health information, whether it's sending information to people who've been diagnosed with diabetes to remind them of what they're supposed to be doing and give them an opportunity to text in questions 24/7. But anyway, I'd like to, in the time that we have left, open for questions or comments.
Okay, I've unmuted the phone lines if anybody has any questions they'd like to ask out loud. In the meantime, Holly, I did get one texted question. They said, let me pull it up. I know this research that you did was mostly based around children. Do you have any idea if there's research regarding elderly populations, as rural areas tend to be quite full of elderly people and patients?
No, there isn't. Not that I've ever seen. I've never seen any specific research, but that would be a great group to work with. Because people have a misconception that the elderly are not using cell phones or text messaging or social media, and they really are. The rates are actually really high. One of the things you do have to work around with is visual acuity, and making sure that that they have the visual acuity, or that they've got that they're able to see what you're doing. But if you did video, even if they couldn't see it, they could hear it. And so there is that, is working around, the elderly and health literacy becomes a big issue because of visual acuity, but then also hearing issues. So you'd have to work around those, but that would actually be a really great group to work with. And so if anybody's interested in that, get in touch with me and maybe we can put something together around that.
Sure. And do you have a slide or want to share your contact information, Holly?
Oh, I'm sorry. There it is.
Excellent. So anybody else, any questions? And I do have the chat line open, and those of you who know how to text me can do that as well. We can leave the line open for another minute or two if anybody wants to text or chat or ask any questions. In the meantime, we really appreciate you coming on today. I appreciate Dr. Seabury sharing her research, and I think a lot of great information. If anybody needs to contact her, you see her contact information on the screen. Mine is Allie Orwig. It's my name, and you can contact me at aorwig@indianarha.org. We will be posting this video to our YouTube channel, so if anybody needs the link to that, it's certainly shareable. And I haven't seen any other questions come in, so I will thank everyone for your time today. Hope you have a great afternoon.
Thanks.